Okay, guys, so this is your exam 2 review for health assessment. You're halfway through. Good job. Okay, so contents of exam 2. Do not be intimidated by this list. It looks long, but it's really not bad at all. So you have health history, interviewing or intake, communication, nutrition, your head to toe assessment, and then any additional like assessment stuff that goes along with assessment. So cultural and mental status, substance abuse and violence. You have nursing documentation and informatics, hair, skin, and nails. That's a big one on this one. Eyes, ears, nose, mouth, and throat. There's also quite a few on those. Um, you have the cranial nerves, but like I said, that before we started, that's very minimal on this. It's probably going to be covered a little bit more later on with neuro, and we'll go through that. And then also circulatory issues, same thing. I know you guys just started going through cardiac and respiratory, but there's a little bit tied into the eyes, ears, nose, mouth, throat questions that are relevant to both the cranial nerves and circulatory issues. And then you do have some math, but again, it's very, very minimal. And we'll go over everything, okay? Okay, so health history and initial interviewing with patients. So you want to use open-ended questions to obtain history and background of why they are seeking care. So the patient will describe their overall health status once you get them to open up with that, basically an open-ended question asking, why are you here? Why have you come in? What are your problems that you're seeking basically an explanation on? So for allergies, we always assess allergies right from the get-go. You want to determine the quality of their allergic reaction. So if they tell you that they have an allergic reaction to some medication or something, have them describe that quality, describe what the reaction is like. That's the best way for us to obtain the most information based on that allergy. Excuse me. For overall appearance and physical health, as well as psychosocial and potential anxiety they may have, you want to objectively observe the patient and then also take in what the patient is stating subjectively. So you want to look and see and also listen to what they're saying. Okay, so assessment. Again, we kick off the nursing process at PI with assessment. We're going to do our head to toe. So this is going to become a really big thing when you guys get into the med surg unit. You'll be doing head to toes all the time. And the basis of like the scope of like what you're doing, the head to toe, is you're looking at the head, the neck, the heart, lungs, abdomen, and the extremities. There's a lot more involved in it. That's kind of like the umbrella of what the head to toe assessment is. And we're kind of piecing that together. So you want to use cultural competency with assessment. Do not assume all patients are capable of communicating in English. You always want to consider the context of the patient's background. And patients always have the right to incorporate their cultural practices into their own care. No matter what your views are or what you think, they have that right. You want to consider variations with age. So from the time they're born to the time they die, there's going to be all different variations that we see. We see the most variations with children and elderly, right? So if a sensory or neuro assessment is needed to be obtained with an elderly patient, we want to be sure that the patient is capable of following directions, is alert, and is cooperative. You want to make sure that that patient, that elderly patient, is in the right frame of their mental status to be able to do an assessment on them. Otherwise, that might lead us to false conclusions. Children and elderly patients have variations in vitals, how they physiologically react to certain diseases, and how they psychologically react to situations. Health behaviors. So I think that everyone can concur that when they go to the doctor's office, like the most common thing that they're always asked is, how many drinks do you have per day? Do you smoke? Right? Those are negative health behaviors. That's important to know. Validation is also important to know. Validation is the assessment portion of confirming a patient's subjective data with the physical objective data obtained. So basically, a patient will, say something that they're experiencing physically, but it's our job to go in and do our assessment and gain objective data, whether that's labs or whatever it is, the objective data to validate what they're claiming. Okay. So violence, trauma, and abuse suspected. So during the assessment, if we suspect any of these, we need to do what is necessary to intervene and implement care as part of the nursing process, right? ADPI. Abuse. It may be elder or child. It's not limited to that. But that's what we're going to be most concerned about because we are mandated reporters. And that's a huge part of the nursing scope of practice is being a mandated reporter. So some things to consider with abuse. You want to consider patterns of abuse, types of physical evidence, such as bruising. What are the parents stating? So if you're working with a pediatric patient, what are the parents, if there's suspected abuse, are they changing their stories? If they are, that's a red flag. You want to also consider the location of bruising or other types of physical trauma on the body that you may see, whether that's cigarette burns, there's all different types. But those are the things that you want to consider, and those are important to know. Okay, nutrition. So status data is weights and intake history. So the intake history is like usually done by like a 24-hour recall food journal of the last 24 hours of what they ate, right? So status data is weights and intake history. Patient weights should always be obtained at the same time of day and in the same clothing, if possible. You'll see that when you go into med-surg, there'll be a way to weigh them on the beds too, to take weight on the bed. And daily weights and INOs, your intakes and outputs are really, really important for certain patients. So when you get to med-surg, you'll see how strict that becomes. And California nurses are pretty good about it. Okay, so hydration status for infants. Some fontanelles are definitely going to be indicative of dehydration. That is, like if they have second fontanelles, they definitely have dehydration. But also check their skin turgor and mucous membranes because that could show dehydration as well for infants. So the fontanelles you guys will get to this, but just for a little background, the fontanelles, you have the anterior fontanelle and the posterior fontanelle. And it's basically those sutures haven't closed of the skull. So it's like almost like an opening in the skull that you'll feel. And you'll feel when it's, if it's sunken or depressed, that's dehydration. It should just be like average or normal feeling. I shouldn't say normal. You should never say normal. But you'll know the difference between either bulging or dehydration. Bulging is always an indication of increased cranial pressure. With elderly patients, the most obvious thing that we're going to look at is that skin turgor, right? So skin turgor we usually look at on like the clavicle area. And if we pinch the skin, not pull, if we pinch it with our fingers and then let go and look at the skin, if there's some tenting of that skin, that means that there's poor skin turgor and the patient is dehydrated. Okay, so hair, skin, and nails are a good indicator of nutritional status as well. Nutritional status, by definition, is the balance between nutrient intake and nutrient requirements. Okay, so hair and nails. So brittle or dry hair can be an indicator of underlying health problems or nutrient deficiency. So alopecia is pictured here in the top image. It's generally an autoimmune related disorder. My sister actually has it where the hair falls out in patches. And sometimes it can come and go. Sometimes it can, there's different levels of severity with alopecia. Some patients, they have it so bad that it's like all in patches and they just decide to just shave their head. So nails. Nails may also be a good indicator of any underlying health problems. So clubbing. This is possibly a circulatory issue such as COPD. Brittle nails, fungal, pitting. There's tons of different nail conditions. Delayed capillary refill for more than 2 seconds is indicative that there's like not good perfusion. The oxygen's not being perfused to the extremities well enough. Any observations made of the nails usually needs a follow-up, especially fingernail clubbing. Important to know. The other thing I want to say about hair, skin, and nails as a whole is if the body systemically starts to fail and there's some sort of underlying disease, it's gonna be most obvious with hair, skin, and nails because the body kind of like collapses. Like I think about it like collapsing inward on itself. So, you know, the body is not going to perfuse like the extremities and the outside, right? It's going to take care of the vital organs first. Does that make sense? Okay. So skin. The skin is the largest organ in the body. It is an important indicator of circulation, nutrition, as well as signs and symptoms of systemic diseases. Elderly patients decline in elasticity and subcutaneous tissue. Diaphoresis, know what this term is? It's just sweating, and you're going to start hearing it a lot. If you haven't gotten used to the word yet, you will get used to diaphoresis and diaphoretic, which is the adjective form of saying like sweaty, basically. So my patient's really diaphoretic. You'll start hearing that used a lot in nursing. Lesions. So do you guys know the difference between ecchymosis, purpura, and petechiae? So ecchymosis is like a overall like really big bruise. Think of it as like purplish to blue, and it's just really large. It's, you know, it's been done by some sort of trauma to the underlying tissue. Purpura is basically like a leaking of the vessels, and this happens to elderly patients a lot. You'll see that like they start to get this like weird, I shouldn't say weird, but they'll start to get like these spots on them that are the purplish blue, but they're like smaller. It's not ecchymosis. Ecchymosis can happen easier with elderly patients, but you'll see a lot of purpura on elderly patients. And then petechiae, which both purpura and petechiae are like, they're like dots almost, but petechiae are almost like they're smaller and they're more pinpointish. And that's usually caused by like some sort of asphyxiation. Okay, so priority when handling open lesions. Do you guys know what that is? It's the first thing we're gonna do before we do anything else. I'm gonna put on gloves,
And
right?
hygiene?
Standard precautions. Wash hands, of course, but you want to have gloved hands when there is open lesions. Uh-oh. Am I breaking up or is someone who's talking breaking up? I hope you guys can hear me okay. Yeah? Okay, cool. Was someone trying to say something? Do you want to? No? Okay, we'll move on. Pressure ulcer risks. So immobility is number one. If a patient can't move, that's the biggest risk for a pressure ulcer. There's also a variety of different other risks. So we have incontinence or wetness. Being elderly is a risk. Being frail or thin is a risk. There's more than that, but just know immobility is number one. You want to use the Braden scoring to assess for risk. So know these values here. Very high risk is less than 9. Something that if you saw like 7, that would be severe. That would be a severe risk for a pressure ulcer. You guys doing okay? Let me know if I'm going too fast. Okay, so pressure ulcer staging. Stage 1, the skin is unbroken, but it's inflamed. When you go to blanch it, it's unblanchable. So it's not going to blanch white at all. It's going to be red. Stage 2, the skin is broken through to the epidermis or the dermis. So either of those first 2 layers of skin. Stage 3, the ulcer extends to the subcutaneous adipose layer. Stage 4, the ulcer extends to muscle or bone. Do you guys know where full thickness loss occurs? What stage?
3.
Okay, so I see 3 and I see 4. It is
Stage
3.
4.
Mm-hmm. Good job.
I didn't at the beginning of your question. Oh, sure.
Okay.
Yes, you meant full
Skin
thickness
continue, just know
skin,
these
but not
terms.
tissue.
Pallor is paleness. Oh, can you guys say whatever you're trying to say once more?
Can you repeat your last question? We didn't get the question.
For full thickness loss, at what stage does that first occur? So you're going through each layers of the integument, right? It's going to be stage 3.
Okay.
And then
Yeah.
a question just to clarify. So full thickness is stage 3, and that's full thickness through skin, and then stage 4 is full thickness through skin and tissue. That's the difference between the two.
Yeah, because you're starting to go through muscle and then you're seeing bone at that point.
Quick question. Can you
Yep.
just touch on like unstageable relative
Yes.
to?
So unstageable is usually it'll end up being a stage 4, but unstageable is where you see like the SBARs on there and you cannot see to what level. You can't see bone yet. You can't see what level of the tissue it's at, or the skin layer, until you debride it. But it's likely it's a stage 4. Okay, so pallor, paleness, erythema, redness, cyanosis, blue. And that's indicative of a circulatory or perfusion problem. Jaundice, yellowing. And that's indicative of excess bilirubin. And often it's a liver problem, right? Okay, eyes, ears, nose, mouth, throat. For eyes, Perla. We always need to know Perla. So pupillary light reflex is going to show constriction. You'll see that you'll have what's the word? Starts with a C. Someone help me out.
Constriction?
You have constriction, but you also have the other eye that's being consensual to it. That's what I was looking for. So when you have the light on this eye, you always hold underneath. Don't ever hold it directly in front of the eye itself because that's just painful. You'll see the pupil in this one is also consensual. So that's 2 tests in one. If one pupil is non-reactive after a TBI, so traumatic brain injury, you want to think increasing cranial pressure and intracranial abnormality. For accommodation, so that's where you tell them, okay, go ahead, look ahead, you have them stare at something far out, and then you're going to have them follow. This is a Sharpie, but you'll have like your pen light or something, and they follow it inwards. You could use pen, I guess. And as they do so, and their eyes converge and constrict, they're accommodating for that close-up vision, right? So accommodation is convergence and constriction. Strabismus is lazy eye, and that is the lazy eye that's like a weak ocular muscle issue. So the way we test strabismus, we can look at it with the corneal light reflex, which I did with some of you guys last week, where you hold the light above and you shine the light and you'll see a pinpoint light reflection in each of the eye, and it should be like clockwise in like symmetrical areas. If it's like one is here and one's over here, that is an indicator of strabismus. We can also test strabismus with the cover-uncover test, because when it's covered, the eye muscle tends to weaken and it can fall. And then if you uncover quickly, you can see it snap back. Additional eye conditions can be amblyopia. So some people get amblyopia and strabismus confused because they're both termed lazy eye. Amblyopia is more of where they kind of look like one of their eye is like sleepy, right? Anisocoria is unequal pupil sizes. This is most often, I think, due to like some sort of trauma to one of the eyes. But one pupil will be normal and the other one might be really large. Presbyopia is just the natural loss of vision as we age. And then we also get cataracts and glaucoma, and there's other eye conditions for sure. Okay. Eyes, ears, nose, mouth, throat, ears. So vertigo versus dizziness or syncope. So vertigo is often caused by an inner ear problem. It gives a sensation of rotational spinning. So the patient will probably say something like, I feel like the room is spinning. That's different from being dizzy or syncope, where syncope is you're fainting, right? So what is the normal color or appearance of the tympanic membrane if you're looking in with an otoscope?
Gray?
Yeah, Isa, pearly gray. Good job. Okay, eyes, ears, nose, mouth, throat. So looking at the nose and the mouth. Eyes, ears, nose, and mouth are conditions they're often impacted most with pediatrics and elderly patients. For the mouth, the elderly often have problems with like their dentures and teeth. So if they come in and they're having that issue, a big concern for us for that elderly patient, because elderly patients already have malnutrition problems, is going to be it's an issue for impaired or imbalanced nutrition. Okay. Oral care is a necessity in the hospital. You are going to get this drilled into you how important oral care is. I don't think I want to be an ICU nurse because I did not like oral care and I do not like suctioning. I don't like doing the suctioning with people on the ventilators. It's the one thing that like, I was like, but there's this protocol called the VAP bundle. VAP, does anyone know what VAP stands for? So it's ventilator associated pneumonia. And we need to do everything possible to prevent that because we don't want extra secondary issues hospitally acquired, right? So it's a list of different things that we do, including like keeping the head of the bed to a certain degree, but oral care is one of the things on there. Oral care is a necessity. It's very important. I don't know if I'm going to say it right, candidiasis. That's basically where we see the white patches in the mouth. Yeah, go ahead.
Could you repeat what VAP stand for one more time? Sorry.
So VAP it's not important to know for the test. I just threw it in there. What is important to know is that oral care is a necessity. It's important. But VAP is ventilator-associated pneumonia. Yeah, thanks, Melissa. So candidiasis is white patches in the mouth. And yes, Isa, I saw you throw up thrush into the chat. And this is often seen like with patients who are immunosuppressed, and then also in children too. And then I think like glucocorticoids, like the inhaled glucocorticoids, you want to, warn them to like rinse their mouth afterwards because they can develop that. So for peds and abnormal dental development, the thing we want to suspect is that like, so if we have like a preschool age child that is having, some dental issues, the first thing we're going to think about is, okay, they're probably still using a baby bottle and they probably have baby bottle tooth decay. And that's like the culprit usually. And that's like if they're having juice in it too, right? So we help our patients transition. At that age, you shouldn't be drinking from a bottle. But it's still something that a lot of parents will give to them out of like just easiness, right? Okay, so African Americans and cyanosis. The way it's really, really difficult to see if an African American patient is cyanotic because of the pigmentation of their skin. It's really hard. Like for someone like me who's really light, like you'll be able to see easily if I turn blue. But it's not as easy to see on a darker skinned patient. So the way we look at that, the best way to look at that is the oral and buccal mucosa. The buccal mucosa is the lips, and then oral mucosa. If you see in there that there's signs of like cyanosis, then you need to get them help. Okay, eyes, ears, nose, mouth, throat. So looking at the throat and neck, know these different terms. Tracheal shift is pushed to the unaffected side. So there's a variety of things that can do that. Pneumothorax is not one of them. So do you guys know what pneumothorax is? That's one. Yep. Tracheal tug is an abnormal downward movement of the trachea. Trachea pulled to, if a trachea is pulled, it's being pulled to the affected side, and that can be different conditions. No tracheal shift for sure. A patient comes in and cannot turn or move their neck from side to side. Which cranial nerve will you assess? They can't move their neck. Which one are you going to assess?
11.
Accessory.
What is it called? Yeah, there it is. So cranial nerve 11, the accessory nerve. How will you assess this cranial nerve?
Shrugging of shoulders and turning the neck.
So, yep, you're going to have them shrug their shoulders. Good job. Okay, medications and nursing math. So medication terms to know what peak is. So the peak is the highest effective concentration. No trough, that's the lowest level before the next desired dose is needed. The number one cause of medication errors is distraction. And I've actually seen this firsthand on numerous occasions with nurses that I've worked with. It's usually like something like a pain med. Hopefully it's like never like a do med that's like they need to get like some sort of life-sustaining medication, whether it be by IV or whatever, into the patient. It's usually like, you know, something like they need something for the pain, whether it's even sometimes severe pain, which is not okay to forget, but it happens. Distraction happens. They get the calls, you know, they get pulled to this direction to help somebody out. So yeah, that's the number one cause of medication errors. Math to know these conversions, know that 1 tablespoon is equal to 3 tablespoons, which is equal to 15 milliliters. And then know your conversion from pounds to kilograms to pounds. Is everyone comfortable with that? Okay, so for any of you who are not, you're going to go from pounds to kilograms with division, and we divide the weight in pounds by 2.2. To go from kilograms to pounds, we're going to multiply by 2.2, right? Okay, so nursing diagnoses and documentation. So for nursing diagnoses, it's the problem related to the etiology. So this is just like the format, right? The 3-part format. I've gone over this, I think, with some of you, maybe all of you, I don't know. Problem related to etiology as evidenced by the signs and symptoms. Nursing diagnoses will never have a medical diagnosis component. That's important to know. Don't ever make the mistake. So like if something has heart failure in it or an actual medical diagnosis, it should not be included in a nursing diagnosis because that's not an ANDA approved nursing diagnosis. An at-risk diagnosis is a little bit different. So that's 2 parts. So you're going to have the potential problem related to etiology. You're not going to have signs and symptoms because there's no signs and symptoms yet. There's only the potential for it to happen, and that's usually with like secondary concerns. Documentation. So you always want to cover your butt with documentation. It's important to document the best you can. When documenting a patient interaction, the most accurate way to do this is to include, that's okay, is to actually quote the patient and put that in your documenting. Like you're going to say, patient stated, quote, unquote. This will hold up in the event of like some sort of legal audit, or if you're, you know, if you got caught up in some sort of big legal issue that you could potentially, you know, get called out for, or usually like the hospitals will cover you. I've been told that like the insurance is like most places will cover you, so don't go too much into that. But the best thing you can do as an employee and as a nurse in the nursing practice is document everything and be really strategic about it. Okay, SBAR. Definitely no. Yes, go ahead.
Please, can you roll back to your last slide?
Yeah, of course.
Okay, so for the risk diagnosis, do you mean there will be no signs and symptoms?
There will be no signs and symptoms.
Making your judgment. Yeah, you're making your judgment based on the etiology, the cause of the sickness. Now you predict the potential problem.
Yeah.
You don't, okay.
So for example, like if you have a patient in the hospital who's post-surgery, an at-risk diagnosis could be something to do with like if they're refusing to like use an incentive spirometer or something, or they're not being cooperative in their care of like deep breathing and coughing. A big problem with that is usually like atelectasis. So potential problem would be like inadequate like oxygen. I'm trying to think of the NANDA approved right now. And usually like you see all this stuff in a drop down menu when you're doing your documenting. So don't get too concerned about like memorizing all of the NANDA approved nursing diagnoses. There's certain ones that stick with you, impaired nutrition, impaired like imbalanced nutrition, I should say. There's a bunch. I can't honestly, like, I've had a long day, but
Yeah, it's okay. I get the point.
basically, like you'll use your nursing judgment on what they could potentially be at risk for. Fall risk. Fall risk is one of them. Fall risk related to being in the hospital. There you go. Like they're there and they're on certain medications that could be making them a little bit like
Dizzy,
loopy. Yeah. So that's like an example right there. Okay. That make more sense? Cool.
Yeah. Thank you.
Yeah. So SBAR, definitely know SBAR, know the sequence of SBAR, how you would call and present it, and it should be in the correct sequence. You don't want to start with, this is what I'm recommending, or you don't want to start with, this is what I did. You want to start with, hi, my name is Natalie. I'm calling from whatever unit, you're calling from. I had so-and-so admit this morning, 29-year-old female, and then roll through it in the correct order. It's important to know the sequence. It's important to know what each component includes, so that if you're given a question on, say, like asking what does this fall under, like the description. If it gives you like, the description of background, you should be able to say that's the background. If it gives you the description of assessment, you should be able to say that's assessment. Make sense? So no SBAR. Let me just make sure.
Natalie?
Yeah.
Does medications, because this was something that was unclear to my lab group, do the patient's current medications fall under? Oh, I'll type it.
Does current patient's medications fall under background? Oh, here we go. I can pull it up now. That would fall under background. Definitely. So things like the medical history, previous labs, tests, or treatments, their psychosocial history, their allergies, their code status, it's all going to fall under background.
Natalie, it's Michelle. I was wondering, for assessment, do you have to say like say all the vital signs, unless no, what am I trying to say? Do you have to say all of them, or can you just say what is relevant to what is going on with the patient?
No, the for like the actual vital signs, yes, you should state all those. But as far as like the full like assessment, like you don't have to say what your findings were on everything. But definitely, yeah, the four vitals, so like their blood pressure, their respiratory rate, their heart rate, their SpO2, those things should definitely be included in the SBAR. And then the relevant stuff that's like out of the normal ranges that you get from your assessment should be included in the assessment portion.
Okay, thank you.
Yeah. Okay. Practice questions. All right, so we only got a few. All right, so a male patient with psoriasis visits the dermatology clinic. When inspecting the affected areas, the nurse expects to see which type of secondary lesion: scale, crust, ulcer, or scar.
Yeah.
Yeah, good job. So scale is characteristic of a secondary lesion occurring in psoriasis, although crust, ulcers, and scars are also secondary lesion in skin disorders. They don't accompany psoriasis. So a nurse assesses an 86-year-old patient who is a client at the long-term care facility. The nurse uses the Braden scale to determine the patient's level of risk for skin breakdown. After completing the assessment, the nurse gives the patient a score of 8. Which of the following best describes the patient's risk of skin breakdown? Yeah, nice job, guys. Yep, it's going to be high risk. And again, the lower it gets from that is just going to get more of like severe. Okay, so a consensual light reflex is present when which of the following occurs? So A, the right pupil dilates when light is shown on the left pupil. B, the left pupil dilates immediately after the light is removed from the left pupil. C, the right pupil constricts when a light is shown into the left pupil. D, the left pupil constricts after the light is removed from the right pupil. Yeah, good job. Because I went over that one. Okay. I think there's one more. When comparing air conduction versus bone conduction, which is expected to occur? A, bone conduction is normally 2 times as long as air conduction. B, bone conduction and air conduction are equal. C, air conduction is normally 3 times as long as bone conduction. Or D, air conduction is normally 2 times as long as bone conduction. She didn't go over air conduction and bone conduction with you guys, the ears. Okay. Again, like I said, I'm throwing certain things in here to also like prepare you guys along the way for the HESI that you're going to take at the end of the course. So bone conduction, what?
I was gonna say my first thought is the fact that your bones are what are conducting all of everything. So it's just a matter of
they're
how
both
much.
sound conduction. Bone conduction are like it is like used by like vibration of those inner bones. So like which you guys should have all learned about before even entering nursing school. So like the incus and the malleus and the stapes. That's the bones of the inner ear that are used for conduction. In these malleus, stapes, incus. Okay, I got it. Cool. Yeah, that was definitely like one of the HESI like questions. I feel getting into, or was it HESI or what did we take to get into nursing school? I don't even know. This so long ago. Okay, yeah. So air conduction is normally 2 times as long as bone conduction. And it's just, I threw it in there as, it's not on your test, so don't freak out. Anything that's like, okay, I don't really remember this, like that I just went through with the practice questions, don't freak out about, because likely that is just, it's not relevant. I like for these things to help prepare for the HESI. So I am going to stop the recording. Stop sharing first, and then I'll stop recording. We can have questions.